Listen, I want to thank those of you that have taken time out of your busy lives to come on this webinar with us. We're going to try and answer some of your questions about how this COVID pandemic and the situations that have arisen around it may have thrown a little wrench in your child's care of scoliosis. And Harvey, can I have the next slide? We have an assembled group of experts from really all around the country. Dr. Peter Newton is the president of Setting Scoliosis Straight, and he's out in San Diego. My name is Tom Errico, and I am presently at the Nicholas Children's Hospital in Florida. Dave Clemens is joining us from Camden, New Jersey, whose police force may be the model for the rest of the world, from what I've been reading, which sounds to me like it's a good thing. Dr. Amir Samdani is coming to us from Shriners Hospital in Philadelphia, and a close colleague of mine in New York, Dr. Baron Lahner at Mount Sinai. Just the standard, Harvey, next slide, please. Just some standard webinar instructions. If you have, please submit all questions through our Zoom Q&A. If you can want to, at the end of this, submit any feedback to us, we would be greatly appreciated. The moderators are going to take those questions and ask the panelists, and hopefully we can have a lively discussion about the topics. Next slide, please. Our agenda, we want to just go over a little bit about the introduction to scoliosis, how COVID may have caused some increased pain and definitely stress. We're going to talk about the risk of COVID-19 with scoliosis diagnosis, and does it affect our risk factors. Many children around the country have missed appointments, and we want to talk to you about some alternative options. Some children have had delays in their, teenagers have had delays in their surgery, and going to mention a little bit about vertebral tethering. Next slide, please. So Setting Scoliosis Straight is the foundation that we all represent, and it is a nonprofit established in 2008, and I must say it's one of the organizations, and I am in a lot of organizations, but this is one that I am most proud to be associated with. It has a very high goal of basically raising money and raising education and research to make advances in scoliosis, and the things that we offer our children and adolescents more scientific and more based in science. And that sums it up in a nutshell. And as I said before, I'm very proud to be associated with this group. And now I'm going to pass the baton over to Dr. Peter Newton to give us a little talk on the introduction to scoliosis. These are going to be really short talks. You shouldn't need a cup of coffee to stay awake for these. Peter.
If it wasn't me talking, you would need a cup of coffee. Thanks, Tom. Listen, I just want to make sure that we're all on the same page with what is scoliosis. Go ahead, Harvey. The delay in the transmission of next in this can be a challenge. The normal anatomy of the spine is such that the vertebrae stack up in a longitudinal column. It's a very flexible system in general, although the thoracic spine a little less so because of the rib attachments. Next. But scoliosis is a curvature of the spine that develops for many reasons, which we'll quickly review, but it generates a three-dimensional curvature of the spine, which can be seen in this animation, and which the body is distorted, the rib cage is distorted, and balance of the trunk over the pelvis is gets a little bit out of whack. Next. We recognize and as clinicians classify scoliosis by a variety of different methods, but one of those is based on the causes of the scoliosis. And you can see the difference in the appearance of these three-dimensional images of scoliosis. And some of these are due to neuromuscular conditions. Some of them are due to some syndromes. Some are associated with congenital malformations of the vertebra that weren't formed properly embryologically. And some are just show up in normal teenagers for unknown reasons. So next. The result of scoliosis can be seen in the clinical appearance. And Harvey, you can just click through these. Shoulders, shoulder blades, the asymmetry of the waist, all of these features that we see clinically may signify that scoliosis exists. And you can see the asymmetry in these other images of these children to the right. Next. And one of the things that makes scoliosis obvious to both clinicians and patients is the secondary rib deformity that develops. And when we have patients bend forward, as you see here, we see a prominence of the ribs on the right side in this case, which is due to the spine twisting and pushing the ribs on the right a little bit more prominent. And it's best seen in this so-called Adams forward bend test, which is the way that we screen for scoliosis and also follow scoliosis. It's important to know that this rib deformity is what's pushing up, and it's not an imbalance of muscles or something like that that makes the prominence. It's really the spine twisted, pushing up the ribs. Next. The other important thing inside the chest, of course, is the heart and the lungs. And that space, which gets distorted by severe scoliosis, can, in severe cases, affect breathing and the heart's ability to pump the blood. In mild scoliosis, these organs function just fine. But in severe scoliosis, it may result in impairment of those important organs of our body. Next. Now, typical adolescent idiopathic scoliosis may be seen in 3 out of every 100 patients. And this representation, just to kind of demonstrate 3 out of 100 is what we see in the population. And all these kids standing along that fence are happy-go-lucky people, and 3% may have scoliosis. Again, not causing much in the way of any issue, but some of that 3% will have scoliosis, which becomes problematic later on. Next. The good news is that most of those 3 out of 100 will remain mild and have a very small curve with no clinical significance. However, but there is a smaller percentage of those whose curves will progress. And early in the deformity, males and females are affected equally, but as curves become more severe, there's a much greater predominance for females to have severe scoliosis. Next. So I mentioned before that scoliosis can be associated with other conditions, and some of the typical ones are listed here. Next. So I know that Dr. Clements is going to moderate some questions around just this quick little introduction to scoliosis. And I must say, we've got an audience that we can't see, so it's a little tough to know who's out there. But if you have questions or want to know more about just the basics of scoliosis, please feel free to jump in on the Q&A. David?
Okay, Peter, we already have a couple questions. The first one is, will my rib deformity or the rib prominence go away when my scoliosis is fixed with surgery?
Yeah, that's a great question. And I would say in large part, yes, but not completely. And typically it's not completely corrected because the ribs take on a new shape as a result of the scoliosis. And although we're operating on the spine and we can untwist the spine and straighten it, that rib deformity to some extent remains permanent. So the extent that we can untwist the spine, we will fix the rib hump. but the amount of rib deformity that remains will cause some of that rib prominence to persist. And we typically see about 50% of rib prominence reduction after surgery.
Thanks. Another question.
Can I, Dave, before you ask a question, can I just make a little comment?
Sure.
It's not only surgery that helps benefit the rib hump. If you have a young girl, in fact, my own daughter who has scoliosis had, when we first picked it up, had a very pronounced angular rib hump. And as soon as the treating doctor, not myself, someone else, put her in a brace, I noticed over the next couple months that the rib hump was molded down by the brace. So I think even successful bracing does a very good job at helping with that rib hump.
That's a great point, Tom. Agreed. And chest deformity in general, pectus, carinatum in particular, is another good one that a compressive brace can work on that, the cartilage aspects of the joint and the softness of the ribs to model that potentially into a little bit better alignment. What else you got, Dave?
So we heard you say that girls might get scoliosis more commonly than boys. Why is that?
Well, if we knew what was causing typical adolescent idiopathic scoliosis, I'd be able to answer that question. We don't really know why. There are some theories. We know that scoliosis is related to growth, and girls have a more rapid, distinct growth spurt maybe than boys do. But the bottom line is we really don't have a good explanation of why girls are more likely to have progressive curves, even though boys and girls have equal amount of small curves together. So it's been something that has been a topic of a lot of research, and as we continue to look for the cause of adolescent idiopathic scoliosis, knowing that there's a genetic component to this, but not really knowing what those genes are responsible for and what pathways they control, and knowing that it's growth related are kind of the big things that we do know about idiopathic scoliosis, but unfortunately, the diagnosis remains somewhat unclear.
Here's a question about breathing. Will my breathing get easier after my surgery?
Well, it could if you had if you had a really severe deformity and it was clear that the deformity was large enough to be restricting your pulmonary function. Although the data on improving breathing function after restoring normal alignment to the spine seems like that would be an obvious thing to happen, it isn't always as clear that it does. So I think the patients who are most likely to improve are those that have the most severe restriction. And that's not most patients, actually. So most kids who are having scoliosis surgery don't really have a big enough structural deformity of the chest to cause a lot of breathing trouble. But many may have other causes to their breathing and troubles, and shortness of breath associated with asthma is extremely common in the population. So it may be that you have a little bit of both, some related to asthma, some related to a little bit of scoliosis, and together that might cause some issues. So you could see an improvement, but I think when we test patients, most of them don't have a very large change.
Peter, it would be safe to say, however, that those that need the improvement the most get it.
Yep, those most severely affected are more likely to benefit. I would agree.
Do we have time for one more question?
Sure.
So this is a question about alternative treatments. Can Schroth physical therapy elongate the spine to prevent further issues with scoliosis?
Well, I guess it depends how and when in the cycle of scoliosis development we're talking about. I think it's very clear that Schroth can help patients who have scoliosis understand their deformity and work to maintain flexibility and try to train muscles that will allow you to resume a posture that can be beneficial. Whether or not it has a long-standing change in the natural history of patients who are both either growing and having curves that are at risk for progressing, and how it relates to the reduction in the risk of progression, I think is not entirely known, although there's certainly some anecdotal evidence that it helps patients who are undergoing brace treatment, and it certainly increases awareness about scoliosis and brings dedication to the active treatment of scoliosis in those who are being braced. And I think it's very helpful for patients who have finished their growth and where bracing may not be part of the treatment anymore, but maintaining flexibility and core strength and again, awareness, I think can be beneficial at kind of maintaining core strength and posture and may be beneficial in that way.
Okay, here's kind of an unusual question. Is scoliosis connected at all with the brain?
Yeah, that is a good one. Well, I guess I would say this. We know that there are certain neurologic conditions in which the brain is obviously a central portion of that, which controls the body and the muscles. And when the control of muscles in the body is not perfectly tuned due to an issue in the brain, then scoliosis may develop. And so there's very clearly neuromuscular conditions in which bracing can, in which scoliosis can develop as a result of a brain issue.
Okay, I think that's it. I guess we're going to go on to Tom. Will take us through some of the topics we're going to think about.
Can I get the next slide? I guess we're going to move to increased pain and stress due to COVID, and I'm turning it over to Dr. Amir Samdani.
Well, thank you, Tom. Thanks, everybody, especially our attendees. You know, our mission of our foundation is to really educate, and that doesn't end with just other surgeons. Obviously, we want to make sure we can get good, accurate information to our patients and our families as well, and would love your feedback on how we can continue to improve this. Listen, we'd all have to admit this COVID-19 situation has created increased stress on all of us. Whether you're a parent, whether you're a patient, whether you're a child, a surgeon, it doesn't matter. We're all under increased stress right now. And stress has different effects on our body, our mood, and our behavior. On our body, this can manifest as headaches, as stomach upset, as muscle tension or pain. Our mood can change from anxiety to feeling overwhelmed to feeling sadness or depression. And of course, behavior, whether it's tobacco use, exercising less, getting more socially withdrawn. So we have to really recognize that even though we may not outwardly manifest that we're under stress, that this situation has to be adding stress on all of us. Next slide. So how are we going to manage the stress? Well, the first most important piece is we have to recognize whether we're manifesting signs or not that we're going to be having increased stress. So there has to be a much more emphasis on getting regular physical activity and relaxation techniques, whether it's reading a book, meditation, yoga, whatever works for the individual has to really be increased. You know, I'm a parent of 4 children, and I can tell you, you know, we are really pushing them to every day get some level of activity, to read, to engage in yoga. Of course, other things such as keeping your sense of humor, spending time with family and friends in a socially responsible manner, a socially distanced manner is important, and setting time aside for hobbies. Next slide. And our tactics for pain management, again, it really is going to tie in with stress. I want to really emphasize exercise, and perhaps cardiovascular exercise will have a more beneficial effect than other forms. Calming our body and mind, as we stated earlier, and have to emphasize flexibility. I think Peter had touched on that with Schroth, and certainly any form of exercise that will encourage flexibility will be beneficial during these times. There may be some focal areas of pain. So of course there's the overlying picture of being under stress, but there may be focal areas of pain that can sometimes, one can see with scoliosis, and applying either ice or heat. And for different patients, different modalities will work better than others. And of course, we recognize that it's not just our exercise, but our diet, a diet that's high in the anti-inflammatory nutrients such as nuts and oils and vegetables would certainly help. And of course, there are rare circumstances where pain, if it has certain red flags, can be an indicator that needs to be evaluated more urgently. And if it persists or is waking you up at night or other red flags, it'd be important to contact your doctor. But again, that is extremely rare. Thank you.
Okay, we can start with some questions. The audience wants to know what curve amount is considered mild and what moderate or severe.
Sure. So, there's no strict criteria as to what would constitute mild versus moderate versus severe. But if we, start with curves that are not amenable to some of our treatment, that are so small that they're not really in the category for our treatment paradigm. So we'll say, curves that can be followed, generally curves less than 25 degrees, curves that can generally be braced in children that are growing between 25 and 40 degrees would likely be moderate. And then curves as you get past 40 or 50 degrees into the surgical range would generally be classified as the more severe curves.
Okay, you mentioned exercise being good, and you mentioned some low impact, but this question comes from a weightlifter who wants to know, will lifting weights increase his back pain related to scoliosis?
Yeah, so, back pain is such a broad topic, and there's so many different factors that can affect back pain. The good news is generally with scoliosis, if we really isolate scoliosis, it's not a painful condition. It's only in a subset of patients and in very specific locations, i.e. if you're having lower back pain, like much of the population does, that's a very different category than if you're having pain across your rib prominence and your thoracic side on the right side. I think it's really specific to the patient, Tom. I would suggest that whatever form of exercise is taken, whether it's cardiovascular, low impact, whether it's weight training, to be done in a very incremental manner, to start slow and in small amounts and see how that makes you feel. I mean, if you're lifting weights and you're starting to get back pain, I think your body's telling you that that's not the right thing to do. But if you're able to tolerate it and slowly and gradually work your way up and it helps your pain, then you know that's the route that you go down. And I have patients in both camps. Some will say weightlifting's been very beneficial to help with their comfort, and others will say they can't tolerate it.
Okay, I would only add real briefly, if you're going to do weightlifting, which I encourage my patients, make sure you use good form. Last question for you, Amar, is patient on the line had surgery 8 months ago and they're still having some pain. Do you have any advice for them?
Yeah, so, having some degree of pain after surgery, whether it's in the immediate post-op period, whether it's 6 months or a year out, is not uncommon. And there's different triggers for this. Some of this may just be related of the nature of what was done. In order to perform the surgery, the muscle planes have been disrupted and they're going to heal and it's going to get better. And the vast majority of times, you're not going to have any significant pain, but there may be a subset that are susceptible just from the surgery itself. And then of course, there could be activity-related pain as well. Some patients may want to do more than they're really ready to do. That can spur pain on. And my advice would be that to try to really figure out what the trigger of the pain is. And if it's a certain activity, then that's an activity that we're going to need to avoid. But it is important to stay active, to stay strong, and try to restart after a certain period of taking time off.
And talk to your doctor.
And of course, talk to your doctor.
So Dave, you want to introduce the next speaker?
That's me. So, obviously with what's happening, people are concerned that a condition that they have may put them at risk for having a more serious type of COVID-19 infection. It's an interesting disease in that some people get nothing and some people it can be fatal for them. And there are some risk factors that we know about. But fortunately, scoliosis is not one of the risk factors for a severe case of COVID-19. That doesn't mean you can't be a carrier, or you can't have a mild case of it, but you're not at any more risk than anyone else because you have scoliosis. Next slide. For some reason, being under the age of 18 or 19 seems to make it less risky. You're going to get the more severe type of COVID-19 infection. It's very rare for children and adolescents to get the severe type where they end up on a respirator like some adults will. There does seem to be a new, very relatively rare syndrome of a multi-system inflammatory problem. In other words, the blood vessels, the linings of the breathing tubes get inflamed, and it may be due to a mutation of this new virus. However, fortunately, it's pretty rare, and once again, it's in no way connected or put at higher risk by people who have scoliosis. Next. So who is at risk? People who are older, usually 50, 60 or older, and with significant pre-existing medical conditions, such as if they're overweight, if they have asthma, if they have diabetes or heart disease. And these are adult diseases, not childhood asthma or childhood diabetes. And people who have a weakened immune system, such as people who have diabetes or other, maybe cancer, have a reduced ability to fight infections. But scoliosis does not decrease your immune system's response to infections. And so having scoliosis does not put you at any risk for having COVID-19. Next.
Okay. Dave, here's a question. Because we don't know what causes scoliosis, if I have scoliosis, could I have an autoimmune problem and be more prone to having COVID?
There's never been any
COVID is autoimmune. I mean, I'm
there's
sorry.
Never been any research. There's never been any research that links scoliosis to an autoimmune syndrome. In other words, there's never been research that says having an autoimmune syndrome gives you scoliosis, or having scoliosis makes you at higher risk to have an autoimmune syndrome. Certainly, if you have an autoimmune syndrome, you may be at increased risk to getting the infection. But there's never been a proven connection between scoliosis and autoimmune diseases.
Okay, real quick, since topics are all the time we hear, do you think is there a vaccine for COVID yet?
No, and the reports are that there are several different companies working on it. Maybe if we're incredibly lucky and things go exactly right, which they never do, developing vaccines, it might be ready by 2021. But there's never been a vaccine ever in the history of medicine that's been developed that fast.
Yeah, I can understand our hopes and our fears on that one. Well, next I want to take the time to introduce my good friend, Dr. Baron Lahner, who talked to us about missing medical scoliosis care and appointments due to COVID-19 and alternative options. Thank you, Baron.
Thank you, Tom. And it's really great to be with you all here to discuss this important topic. And I'm glad you're sharing your evening with us. Next slide, please. So in this unprecedented era of this pandemic, our interactions in all areas of life have been impacted. And that is very true, of course, in the area of medicine and in care of our scoliosis patients. So, however, we have the ability to connect through telemedicine, and many of us, and the majority of us have, as surgeons and providers, have been able to communicate with our patients through telemedicine. We have the ability to assess on video communications, the appearance of your back, and do the forward bend test that Dr. Newton mentioned. to look at the rib prominence or the bump on the back. And we can take the time on a telephone or video interaction, similar to what we're doing here this evening, but it's a two-way. We can talk about your x-rays, about your condition, about treatment options, and the pros and cons of the various options. Next slide, please. So we did a study, an informal survey of our harm study group, a surgeon membership, to see how we are interacting with our patients. And it turns out that as of June 1st, most of us are doing telemedicine consults with our patients, and some are doing all of their consults via telemedicine, a few, and some are not. But the vast majority of us are seeing at least some of our patients virtually in this format. Next slide. So what should you be aware of as clinics open up? The experience for you will probably likely be very different from what you've had previously. Clinics might have been crowded and very busy, and there might have been some wait time, but now we're doing our best to, or we are very stringently practicing social distancing. So this means spreading out visits and having fewer patients and very few patients in the waiting areas. Face masks are required both by all of the providers, the nurses, doctors, staff, PAs, physician assistants, as well as by the patients and their family members. If anyone has traveled from outside of the country, you may have to be quarantined for 2 weeks at home before entering the clinic or hospital. We're all are encouraged to wash hands frequently, and all the hospitals and all our clinics are doing our very best and ensuring that all take the appropriate precautions. All our visitors and staff are screened and temperatures are taken before entering the hospital, so that it's really very safe. As Dr. Errico said earlier, it's probably safer to come see your doctor in the clinic than it is to go food shopping. So we have very stringent measures in place to ensure safety. Next slide. And just final, so what percentage of patients are being seen now in the clinics as of June 1st? So previously it was probably close to 100% for most of us, with maybe an occasional telemedicine consult. Now the majority are somewhere between seeing no patients in the clinics and seeing up to 75% of their patients in the clinic. So it's coming back. It's coming back a little slowly, but things will return to normal, particularly as a vaccine is found. Next slide.
Okay, Baron, question from the audience. Will my scoliosis get worse if I can't make it to my therapy?
Well, it depends on how severe the scoliosis is and whether you're growing or more mature without growth remaining. So small curve in someone who's reached the end of growth or close to the end of growth is not likely to progress or worsen very much. And so the therapy itself is probably not going to make a big difference one way or another. Someone who has a larger curve and has growth remaining, that growth can drive the curve to worsen. And even in those cases, the physical therapy may not change that natural history. It may to some extent. We kind of favor the Schroth therapy, for example, to help patients realign their posture and also to strengthen their muscles to diminish muscular strain and pain that they may feel. So it really is a matter of growth and the size of the curve that drives this more than anything else.
Okay, are there any online exercise classes I can do at home to help my scoliosis?
There probably are some online classes that you can find, but we have many of the physical therapists and Schroth therapists as well do telehealth. So they do telemedicine or telehealth visits where they can guide you, they can give you a home program, and they can interact with you virtually as well. And as things open up, of course, those visits can be done in person. But I think even beyond this pandemic, there'll be a lot of interactions done remotely.
Certainly. I would just add that, listen, exercise and scoliosis is akin to motherhood and apple pie. There's no one that can question whether those are good things, and exercise in general is good for the scoliosis patient. So on that note, I just want to move on now to Dr. Newton again, if he could talk to us about delays in surgery due to COVID-19.
Yeah, thank you, Tom. I think many of us experienced delays as a result of our elective surgeries being held due to capacity concerns, and in the initial phases of COVID, there was a real decrease in the number of elective surgeries, appropriately so. Next slide. We shut down our elective surgery on March 16th at our place, and I suspect the rest of our panel were somewhere in that same ballpark. Although this pandemic obviously hit all of our cities at slightly different times with a little bit of lag, but not much. And we opened up to a normal full operating room schedule back at the end of May, and we're back to probably 2/3 of our operating schedule by mid-May. So there was about 2 months there where it was very difficult to get into the operating room. And as a result of that, there were patients who typically would have had surgery that didn't. And so now we've got a little bit of a catch-up period to find a place to put those 2 months worth of patients and fit them into this summer season, which tends to be a pretty busy time for scoliosis surgery. If you consider that most of the patients are, at least in the adolescent idiopathic population, are in this sort of school age time when they want to get things done during the summer. Well, the good news is that that sort of a time frame of delay doesn't really provide enough time for the curve to make significant progression. So usually if we get patients into surgery within 3 to 6 months of when they were scheduled, we'd be happy, and that works out pretty well. There might be some where I would really like to get it in quickly. And when that was the case, most of our institutions instituted what they called time-sensitive allowance for surgery, and that time sensitivity increased as we got further and further away from the very acute phase of the pandemic. But so I think everybody is sorted out early that those who really need to get in quickly, we can still figure out a way to make that happen in our systems. And so if that's your circumstance, I would suggest that you talk to your doctor, and they'll figure out whether or not you need to be in quickly, or if we've got some time to take care of this. But most of the hospitals are now back up to a pretty reasonable operating schedule. I know some of the New York hospitals are maybe a little further behind, and Baron can comment on that after we go. Next. So again, our survey, how many of our surgeons in the Harm Study Group as of June 1st were back operating at the 100% level, back to normal. And you can see that about 1/3 were, but that leaves 2/3 that are still at some reduction. And I would guess that if we asked that question even 2 weeks later, that that's moved up quite a bit. So we're getting back to being able to do surgery. And I think the next question then is it safe? Next. There was one question in the chat, or the question and answer that I looked at already about this question. And what extra precautions are going to be taken around the time of surgery in both preparing for it and understanding whether or not it's even safe to proceed at this time? I've certainly had a lot of families ask that question, and one of our participants asked it tonight as well. Well, there's a couple things you should know. First of all, that, and it was mentioned a little bit already, as you're preparing for surgery, most of these hospitals are going to have reduced visitation policies, which are going to limit the number of people in the building. And almost all of the hospitals will be doing some sort of preoperative COVID-19 testing. Highlighted here on this slide is the COVID Collaborative for Children, which at least at our institution is a local county-sponsored function where we're testing kids whether or not they have symptoms or not. Just if you come, and we're testing now close to 600 to 800 kids a day is the goal. So community-wide understanding of what's going on with COVID-19 is really important. And I think you've heard emphasized through the media that one of the keys to us proceeding and opening and resuming our lives is to have a lot of testing. And so as that testing increases and we understand who's infected and how to isolate those people, obviously that makes all of our lives safer. But coming into the hospital right now might be the safest time to have an operation. The social distancing has reduced the virus transmission, not just of COVID-19, but of influenza and all the other respiratory syncytial viruses and all the other cold viruses that we commonly get in the fall are very likely to be reduced. And so our hospital tracks, and all of our other hospitals track how frequent the various viruses are showing up on virus screening tests, and the viruses are all gone. So we've completely decreased the risk of getting an infection from a virus either before or after surgery with this social distancing that's been implemented to help really address COVID, of course, but has a great impact on all the other viruses that we're seeing. Next.
Okay.
I have one more comment, Tom. One of the other questions that I know that came in was, what about if you've had surgery, are you at immune compromised in the time that you're recovering from surgery, and does that make you at greater risk of catching COVID? I think that would potentially be true if, again, you were in one of these high-risk categories, but if you're otherwise healthy, the hit from surgery, the recovery phase is not terribly compromising for most healthy people. And the fact that you're going to be in a hospital that is an incredibly safe environment, particularly if you're a child in a children's hospital, children just don't get very sick from COVID. So our hospitals are not full of COVID patients at the children's hospitals the way it might be at some of the adult hospitals. So again, if you're an adult, maybe it's a little bit harder to sort this out, and there might be, if you're going to be in the ICU and the ICU beds are not available, it could be more difficult. But for the adolescent and the child population, there might not be a better time to have surgery. I'm not sure how the rest of our panelists think about that. And Baron, you've got some New York experience, which is unique from the rest of us as well. You might comment.
Well, yeah, thanks, Peter. Well, I would say your perspective is spot on. We have, at our hospital, we had hundreds of people at any given time with COVID, and many people on ventilators at one point. And now we have very few patients, and they're very far from, these are all largely adult patients, separated from the children's hospital that is adjacent to the main hospital. So there is a separation. And if there are any children with COVID, they're kept separated from our elective surgery patients. I think the hospitals has done an amazing job. Well, first of all, we've really seen the curve flatten, and we're not seeing very many patients in the hospital any longer with COVID. But the hospital does an amazing job of sterilizing. They call it terminal sterilization when someone leaves a room and a new family comes in. Terminal sterilization, frequent cleaning. Everybody's frequently hand washing. We have one parent that is permitted to stay, but not two at any given time. And everybody wears masks. So I think it's, we've been back to about 90%, 95% almost of what we were doing last year at this time.
Yeah, that's
so,
great.
Peter, before I hit you with another question, I just came across something in the news in the last few weeks that I think is very important for the audience. There was a hairdresser in Texas who I guess pretty desperate to earn some money, went back to work, wore a mask, but she had symptoms. And after 3 days of working, she got tested and it turned out she did indeed have COVID. So people were in a bit of a panic about all the people that she'd come in close contact. And we all know how close a hairdresser is to your face and your head. And 2 weeks later, at the end of tracking down 120 people that she came in contact with, no one contracted COVID from her. And I think that we would never have done that experiment,
Yeah.
but Mother Nature gave us an experiment. And if you wear a mask and I wear a mask, we're both pretty safe. And I think that that lends itself to being able to be safely treated for your scoliosis in a hospital setting. So, Peter, this question sort of relates to that. Just in general, is it safe to schedule my surgery during this pandemic, considering we could be in the pandemic for 1.5 years?
Well, I think that's a great point, Tom. Both of those. One is that the wearing a mask, and you as an individual, if you're considering, should I wear this mask, think about this as, what if I'm an asymptomatic carrier? If you wear a mask and you have COVID, you will not spread it to anybody else. And the risk of spreading it while you're wearing a mask is extremely low. And so mask wearing, I like to think of as my social responsibility to prevent infection of those people around me, should I happen to be infected and not know it yet, is one way of looking at it. So, and obviously the other is you're trying to protect yourself. But Dr. Eriko's point of, if we're both wearing masks in the interaction, the risk of each of us is extremely low. And obviously as healthcare workers who are potentially exposed to patients, a high volume of patients, many of whom could be symptomatic carriers, that's important to us as well. And obviously, as a patient coming to see a doctor who sees lots of patients, you want to be sure that your physician is protecting themselves from potentially infecting you. So the mask wear, I really do support from that standpoint, and your experiment from the hairdresser is a great example. As I tried to suggest before, knowing that all of the patients are screened, everybody who's having surgery and coming into our hospital, I know into your hospitals, is getting tested. You're sort of finding a way to get into a safe environment where everything about COVID is sort of known, and knowing that everybody around you is not positive is actually pretty reassuring. So I think that I do think it's safe, and I don't have any hesitation about recommending surgery to my patients right now. And I would say that the risk of not having medical care, especially if you say, well, if it's not safe now, when's it going to be safe? And if it's not going to be safe until we say that we have a vaccine and everyone's been vaccinated, we could be looking easily at another year, and potentially, I mean, at the most optimistic views are talking about 6 months. And even those, I think, we all kind of admit are the best scenario. And you don't want to have your surgery compromised or made more complicated by delaying either. So in some patients, it doesn't make a difference whether you have surgery this year or next year. They're done growing, and the timing of surgery is not absolutely critical. I think you just put this in perspective and look and say, what's going on in my life this year and next year? And some people have come to me saying, hey, listen, I can't do my sports right now. I want to get this thing done so that by the time I do get to go back, I'm fully recovered. So you can look at it lots of ways, but I have no hesitation whatsoever of recommending surgery in this era, given all the precautions that are being taken and the frequent testing. And the hospitals, I got to tell you, are the most strict with regards to maintaining social distancing and mask wearing of patients and screening everybody with temperatures. You're not going to find a place on the planet right now where that is taken more seriously than in hospitals.
And Peter, let's face it, if you're taking 6 to 8 weeks out of your life, it's Never a better time to do it now. There isn't a whole lot going on elsewhere. Let's move on now to catch up a little bit with Dr. Lahner again on being stationary. Is it making my scoliosis worse?
Thanks, Tom. Next slide, please. So, will being stationary make your curve worse? The answer simply is no. But we all know, and Dr. Samdani spoke about the importance of activity. It's helpful to relieve stress. It's helpful for your body, your mind, and your spirit, and your heart and lungs. And so there's a lot to benefit from. Many people will have missed physical therapy sessions and certainly sports activities, but this will not have a negative impact on your curve. You can get a home program. As I said earlier, the Schroth therapists and other therapists have telehealth, so they can do interactions online. And now most beaches are open, so there's an opportunity for exercise, for some swimming, and getting out into the fresh air. Next slide. So what about, how do we predict whose curve is going to get worse? I think we talked about this a little bit at the beginning, and I think the same things I mentioned earlier apply. Sometimes it's difficult to predict whose curve is going to get worse and who's not. You may have two young people, same age, same maturity level in terms of their remaining growth, with a similar curve of, let's say, 15 degrees. And in one patient, the curve may progress and require bracing, for example, or even surgery. And in another, the curve will be relatively stable. Some of this is based on the curve type, its location, how severe it is, and of course, the remaining growth. And that's really when the curve progresses the most, is during the peak growth. We call that peak height velocity. And that's usually before the onset of periods or menarche in girls. And the progression rate varies, again, depending on age and the remaining growth. And there may be some predictive features of the scoliosis that we can take into account as we improve our understanding in the future using three-dimensional analysis of the curves through 3D X-ray. So we're learning a lot. We'll hopefully have better predictions and predictive capability in the future. But for now, if you're not growing, you're not likely to have rapid progression. Things are going to go slowly. If you have a larger curve, a lot of remaining growth, there's more risk of progression. Next slide.
Okay, Baron, I got one burning question for you, and that is, and I'll make a little addendum here. What is your opinion on Pilates? Could 10,000 dancers be wrong? Go ahead.
I think I should probably start doing them myself, Pilates. But Pilates, I think, are excellent for strengthening the core. Some of the therapists might frown upon certain disciplines, such as Schroth therapists often frown upon yoga. I don't think there's any data one way or another about Pilates. And my feeling in general is anything that strengthens your core is generally good. And I think you can take into account various disciplines. We don't want to do anything to worsen the curve, but core strengthening is generally good. And it may help for those who have that muscular pain or discomfort. They may feel better after engaging in Pilates and swimming, for example, on a regular basis.
Okay, and we're going to try and do a little catching up here and move on to questions about vertebral body tethering, evidence regarding this newer surgical treatment option. Dr. Samdani, please.
Great, thank you, Tom. Next slide. So, when a scoliosis becomes severe, it's resistant to conservative treatments such as exercise and bracing. The gold standard remains posterior instrumented fusion. We recognize that you're going to get, in the vast majority of patients, excellent results, but can we find a better way to treat a portion of our patients? Next slide. And in order to answer that, we have to really understand what the pathogenesis of scoliosis is. And It's really this cycle of a curvature which leads to asymmetric loading in our vertebral bodies, which leads to asymmetric growth. The bodies get wedged, their shapes change, and then it becomes a vicious cycle. Next slide. And, can we harness that growth by slowing the growth down on the side of the spine that's longer? And as a child grows, allowing there to be gradual correction. Next. And that's the whole concept about vertebral body tethering. And Peter, our panelist, Dr. Newton, has done a lot of work on looking at the morphology of these bones over 3D, in 3 dimensions. And when it works, there is clearly a change in the morphology of your spine. Next slide. We won't get into the details of the surgical procedure, but essentially, many of these can be done through a minimally invasive approach, utilizing a neuromonitoring approach that allows it to be done safely and with minimal blood loss. Next slide. But how well does it work? And, I'm very proud that our foundation is actually leading the way in collecting that data. We are working with our industry partners and several other surgeon partners to really collect the data to objectively be able to publish as to how well it works, where it works the best, because we recognize there's a lot of information and misinformation out on the internet, and we certainly spend a fair amount of time trying to dispel some of the fake news or the misinformation that's out on the internet. And the best way to get information is to have objective data. And it is starting to come out from all over the States and some internationally as well. But our foundation will hopefully have a very large set of objectively collected data that we can really look at to see how well the procedure works. Next slide. Next. I mean, it's been around now, for almost 10 years, but over the last 5 years or so is where it's really gained in popularity. There is an approval, a limited approval, it's important to recognize, from the FDA. And the patient that it's optimal for, it can certainly vary by surgeon, but most surgeons would agree that some degree of growth remaining is necessary for it to work if those bones in the spine are truly going to change shape. And the curve magnitudes can range anywhere from 40 degrees, maybe up to 65, perhaps 70 degrees in flexible curves. Next slide. And we have to recognize that it's not a one and done. In fact, tomorrow I am operating on a child that I had tethered who had overcorrected and is going to require a spinal fusion. So that is going to happen in a certain percentage of patients. And when we've looked at our patients, it ends up being about 20%, but perhaps it can range as high as 50%. It's really, we're in our earlier stages, really understanding what percentage of these patients will require reoperations, because we recognize that early results with a lot of procedures are going to be excellent. We really want to follow these patients out further along. If we look at the ability to avoid fusion, again, that range can range anywhere from 60 to 80%, depending on depending on the patients and how long they've been followed for. It is not uncommon for the tether itself to break, although vast majority of those would not be obvious to the patient and just picked up on X-ray. Next slide. But listen, I mean, we recognize that this concept works, and for the right patient, this is a spectacular operation. But if we extend our indications, then perhaps we're not going to be able to get consistent results that are good. And we have to really make sure that we perform it on the patients that we feel have the best chance of it working. But we are working with our industry partners, with the FDA, and our foundation is playing a central role in really pushing this field forward. Thank you very much.
Dave?
I think Tom might have
Any
frozen.
questions for Amar? No?
I think we've had a pretty good hour session here, and I know from David and myself, we want to thank our contributors, and we'll do this again in the future. Keep an eye out for us. We'll be back.
Great. Thanks, Tom, for moderating. I noticed there's still some questions in the Q&A that if our panelists wouldn't mind going and jotting some answers to those folks, even if you stay on for a little bit, we'll try to get to your questions as well. But Dave, we got you on mute, Dave. There you go.
As Tom mentioned, we're going to be doing a couple more of these. Probably the next date will be in July 23rd, and then in August 20th. If you enjoyed what you saw and you'd like to donate to Setting Scoliosis Straight, you can go to our website to help us keep doing these webinars for patient education. So thank you all for participating, and thank you to the panelists, and thank you to our sponsors. And if you wouldn't mind answering a few survey questions, it'd be helpful for us to be able to design better webinars in the future.